It's my pleasure to introduce our first speaker of the day, Dr. Isma Rafiq, a consultant cardiologist at the Royal Brompton Hospital and a new advisor to our trust, offering indelible support. Dr. Rafiq is the Brompton lead for the high-risk heart disease pregnancy service, and so she is uniquely qualified to talk today of pregnancy and Marfan syndrome. Welcome, Dr. Rafiq.
Good morning, everyone, and thank you, Victoria, for such a lovely introduction. And I feel honoured to be here to support my patients and do anything for them to make sure that they have a fulfilling life. So I think I've been given the most difficult task of the whole day, because I think pregnancy is a very important topic and an important part of everyone's life. Where we say it's more important for the females, I think we are sometimes biased, where kids are very well wanted for the mothers, also for the fathers as well. And I think with this talk, I may well be able to support lots of people, even including males who would like to have children and move life forward. So I think it's very important to remember the person who basically helped with the diagnosis. And in 1896 was a time where first time the Marfan described, and it was diagnosed in a child of year 5. And of course, over that period of time, we have progressed and made the diagnosis clear. And with the introduction of genetics, I think things have been dynamically moving forward, and we have lots to offer to our patients. So I think thank you to this man, and thank you for the team up till now, that we have been progressing well and supporting our patients. I think before I move on to the nitty-gritty of pregnancy, I think it's very important to understand that in keeping with the connective tissue disorder we have, there are a number of systems in the body which can be affected. I've got to focus on heart, and probably with the curved spine as well when I'm focusing on pregnancy. So I think it's extremely important that keeping with this diagnosis, that the aorta is monitored, the left side of the heart is monitored, and all other complications are addressed in a timely fashion. And from my point of view, it's very important that patients with Marfan syndrome who would like to pursue a family get appropriate counselling, and they can go on this venture with a good plan in place from them. So there are lots of myths about pregnancy, and as I was mentioning, that there have been patients in the past that has been counselled against pregnancy, and I think there's points to that when the whole concept of MOP conception counselling is to negate those myths for you and make a proper assessment and support pregnancy. I think it's very important that when we are looking through pregnancy, there's a multidisciplinary management for pregnancy and delivery. And equally, I think it's very important that the post-delivery care is executed in a timely fashion. So as you can see, I mean, pregnancy is challenging. Every part of the body is affected, and from my point of view, I think I will basically home on the cardiovascular and the musculoskeletal part from the Marfan syndrome. But it's not an easy business for females. It's very, very risky. I think the other point before I move on to anything else is to remember that we have 3 phases in pregnancy, which is your first trimester, second trimester, and third trimester. And in each trimester, we have different changes where your cardiac output, blood volume, and heart rate and stroke volume, everything changes. Your heart rate and stroke volume is basically equivalent to your cardiac output. And where you on normal when you are not pregnant, you may hang between 5.5 to 6.2 litres, but in pregnancy you go up to about 8.3 litres, and you peak your cardiac output at 24 weeks. And then when you are really fully term at that time, there are a number of other issues, that the baby is compressing on the IVC and the aorta, and that also compromises a number of things. We also have to remember that when we are fully pregnant and we are going through that phase, the hormones, the estrogens and progesterones all over the place as well. So again, I would say that although on paper it may seem simple, but actually it's not that simple for the female bodies, or the stress they undergo. So I think we start off with maternal complication. I mean, normally they say that if the aortic root is less than 40 mm, the chances of having a dissection is very low. But despite that, there's still total risk of 1%, and overall risk is 3%. And in some papers, they have said 10% as well. But I think the key to remember also here is that although we say it can occur at any time, but 50% of the dissection occur in the last trimester and 3% is in the postpartum period. I think if you do have significant dilatation of the aorta and you're starting on that trip, it is a very high risk pregnancy, and it is a no-go area, and it's a class 4 indication that you should not fall pregnant until the issues addressed. And I think at the same time, it's very important to understand if you do have other issues associated with the heart, just not the aorta, the LV dilatation, or is any associated Marfan, cardiomyopathy, or mitral valve disease, you really need to be assessed appropriately. Again, I would say we have to be very careful here. Although I'm highlighting the maternal complications here to you, the reason I'm doing that is that these all can be prevented, all can be streamlined if you do want to pursue pregnancy. But the key here is the preconception counselling. My next slide is a very famous paper which basically tells why people do end up in a difficult situation. And I thought it was very interesting that mostly it was because of the lack of knowledge. People don't know they have Marfan syndrome and they present with acute dissection. And also, I think we don't have much serial data in pregnancy to say that how much change will be in the aorta. We've got little papers here and there and some literature which also makes it challenging. I think the take-home message from here is that any aortic dimensions which are less than 4.5 remain stable, and people got on with their pregnancy. Type A was usually common in people who were unaware that they had Marfan syndrome, and I think it's very difficult to predict type P dissection these ladies. Again, I would say that when you go back to the ESC guidelines, they say anyone less than 40 mm are very safe to have a pregnancy, and people who have an aortic root diameter between 40 to 45 mm, they're okay, but you have to consider other factors such as what has been the rate of growth of the aorta in the last couple of years, or is there a family history of dissection, or did they had any issues in the past which need addressing? For example, they did have a dissection and we needed to do an aortic root replacement, but in those case scenario, I think we're usually pretty safe. But there are a number of factors that need to be considered, and I'll talk about them as I go through. This is just a diagram to show there's some data collection which I've seen that during pregnancy, aorta can increase by sort of 1 mm to 3 mm. And there are certain papers have shown that the growth can be quite rapid, and it's very important that these patients are observed during pregnancy. Normally, the data out there is from echo. I do believe that if you're starting off with a normal aortic root, echocardiogram is pretty good. But if you do see serial changes during that pregnancy, I think MRI will be more sort of a gold standard to basically pinpoint the dimensions. But after pregnancy, they also documented that 2/3 of the ladies had their aorta go back to where they started with, which is a very interesting finding. But I have to say that although we see this data, the spectrum of these ladies having aortic dilatation or progressive aortic dilatation during pregnancy is very, very different. And we can't put our finger on that. Each case is tailor-made. So I don't think so one Marfan patient can fit in other Marfan patients' shoes. Every person is different, and we have to assess them differently or according to the needs, and manage them differently according to, again, the underlying findings that we do have. So neonatal complication is that if we do have complications from the mother point of view, there can be prematurity. We talk about growth restriction. I don't think so the growth restriction as per se comes from Marfan. This probably comes because we start people on beta blockers. Beta blockers are sort of, they're very cardioprotective, they take the shear stress away from the aortic wall, and they have a benefit to the pregnancy. And although the literature out says that, I mean, there's lots of literature say that the growth is very much restricted, but this is not a big issue. It can be monitored, and once the baby's out, they grow rapidly. So I don't see that as a concern. I think this is a major concern, that if you are genotype positive, it is autosomal dominant, and there's going to be a 50% chance that you will passing that on. Neonatal Marfan, I have to say, in my lifetime, I'm waiting to see one. I have not seen one, or no one has passed anything on to me. But if it does happen, that can be quite challenging at the time. But as we offer fetal echoes, it's usually picked up very early on. Now, moving on to the most important part of the talk is that I think the clarification of the diagnosis is very, very important here. We need to know, do you have Marfan's? Do you have Loeys-Dietz? Is it some other sort of connective tissue disorder? And if we don't have any answers, what is your family trend like? And then depending upon that, we do manage things. I think evaluation of the aortic root and cardiac function is very important. As I was alluding to some of the guidelines, 1% risk of dissection if the aortic root is less than 40 mm, and your dissection rate is higher if the aortic root is more than 40 mm. But again, I would say that between 40 to 45, we do say that it can be safe, but reliant on very other factors. But I will personally say that if we are in between that time, I think we should address the aortic root first before we move on to any pregnancy. So as you can see here, that on my slide, it says that you can do prophylactic repair prior to conception, and if your aortic root is greater than 40 mm, we can get on and do it. And I quite totally agree with American guidelines. The Canadian and the European guidelines are saying greater than 45 mm. I think there's no clear consensus between 40 and 45 mm, but our own practice at the Brompton is that if we do see a female of childbearing age and she wants to pursue and her aortic root is 40 or more than 40, we have been offering pairs, and I will come to that in a minute. So the other thing I think, where I'm talking about preconception counselling, how I'm going to evaluate my patients, of course, echocardiogram is the key here, aortic root, cardiac function, and for me, cardiac MRI is the major key here, because I'm MRI trained as well, and this is what I do. But MRI gives me two-dimensional information about your aorta, and it is very much reproducible, and I would like to have that as a baseline before I say, actually, that's okay for you to have pregnancy. Now, I think this is genetic counselling is very important. If you are genotype positive, I think it's very important that this side of the things are explored, which we call PGD. You need to see a genetic counsellor, and we can refer and ask for P-genetic IVF. And what does PGD involve is basically it's pre-implantation genetic diagnosis. It's an IVF, eggs are retrieved and mixed with the sperm of the partner, and then we have 4-cell embryos, and there's a tissue taken and genetic testing is been done. And then if the embryos have the gene, they've been separated, and the one that don't have get implanted back into the mother's womb to prevent passing the gene on to the children. And this is one effective way of reassuring that the gene has not been passed on to your children, and the Marfan has been sort of eradicated in your next generation. Sometimes people don't like going that route, but I don't think so. It's very, very, I think people are maybe not that aware, because it's just not with Marfans. I do have other patients when you see them, and I think the information is limited. So I really want you to take this home today, that there are options to stop at some point and help the next generations if you do have a genotype. Now, the females benefit for this, because anyone with Marfan syndrome comes and see me, and I have to evaluate them, and I can say, actually, why don't you just have PGD? That will be quite useful for you. Let's explore this. But no boys come and see me. They can be genotype positive. I appreciate the aorta is not going to go anywhere. They're just the sperm donors. So why are we doing that? So what I've done at the moment is that, which is in sort of pipeline, that I set up a little study where I've got 30 boys and 30 girls, and they're all genotype positive, and we've got a pro forma that we're going to fill in to see how much informed they are PGD. They should be given an equal opportunity that their partners can have PGD if they do not want to, if that plan agrees with them and they want to stop passing the gene on. So I think this is a key message, and I think all the men on the call today should also say, actually, I want to see a genetic counsellor. Is that something that I can have offered on NHS as well? I think this is really important. The second thing is amniocentesis. I would say if you have fallen pregnant, there can be this procedure done at 10 to 12 weeks. The problem is there's a risk of 1% of miscarriage, and then you can check the genetics. And I think there could be discussions around risk depending upon if the aortic root is quite dilated. I think if you do, we feel like, or if we, on us reviewing all the data that people will dissect, I think it's important that we go down the route of therapeutic abortion rather than putting yourself at risk. I think it's healthy mother, healthy baby. So I think it's very important. That's another keyhole. If you are well in yourself and everything's fine for yourself, the baby will be healthy as well. And God forbid, if someone does dissect, it has implications for the baby as well. As again already explained, beta blocker therapy is extremely important, and we have lots of our patients with that as well. I think we'll have a case discussion now. For time's sake, I think I probably will slightly move on quickly because I took, I think, there was a bit of drama in the beginning to start my slides. So I think in first trimester, when you do pitch up pregnant, and I think it's very important that we have a baseline echo with the aortic root, look at LV function. I also look at the mitral valve as well. And we start on beta blocker therapy, depending upon the size of the aortic root, which is if it's more than 45 mm and it has progressed very quickly in the last couple of years, I think I'll be very keen to offer a therapeutic abortion because I think you're putting yourself at risk. What can happen is that you can have the aortic root repair and come back with another pregnancy. But if you don't survive this pregnancy, there will be no me and there will be no other baby. So in the second trimester, I normally repeat, or our practice at the Brompton is that we do repeat our echo in every 8 weeks to make sure that there's no serial change in the aortic root. If we do find some change or we progress them, and I think after second trimester, we will ask for an MRI. If the aortic root is between 40 to 45 mm, we are happy to see you through pregnancy. But again, the imaging will be more frequent, including MRI. Third trimester, I think that's my bugbear here, as there's a 50% of risk that where things can go wrong. Again, aortic root, LV function assessment, we continue doing that. In the last trimester, around 32 weeks, I think we start thinking about if everything's going well according to plan, anesthetic consultation, and we do growth scan, because if you're on beta blockers, you do get frequent growth scan to make sure that the baby's growing fine and there's as such no problems or the baby's not too small. If that is a concern, then we consider delivering the baby early. Rather unlikely because the beta blockers do cause growth restriction, but most of the time I think fairly I can't remember a single case in the last 6 years that we have to deliver someone early because of that. I think apart from the anesthetic consultation, it's very important that the timing of the delivery, depending upon the aortic root, where we're going to deliver you and the mode of delivery. So let's move on to the next stage. Again, as I said, delivery planning is very important. Depending upon the aortic root, if it's less than 40 mm, a vagina delivery at term is perfectly fine. I don't think so. I would be worried about anything at all. Your imaging has been stable. You should do well. If you have a borderline aortic root between 40 to 45 mm, I think it all depends upon what are the factors, how quickly it's progressed during pregnancy, how quickly it progressed before pregnancy, do you have in the family history with someone who dissected, and depending upon that, we can go down the route of C-section, or you can say we can have vagina delivery with assisted second stage. What is assisted second stage is that we don't let the lady push. Because with pushing, you change the intrathoracic or intra-abdominal pressure. As a result of, you can induce dissection. So we basically support the woman, and with a forceps or Buntu's cup, we help the baby out. Now, if you do have dilated aortic root and it's more than 45 mm and you decided to proceed with your pregnancy and have you done well, it's been stable, there's no question about that. I will be delivering you in a tertiary centre with a vascular surgeon on call via caesarean section to make sure that we don't have any problems. Now, while we're doing this delivery planning, you can ask me the question, actually, what happens if I'm pregnant and my aortic root was big and I dissected? You will come first, so it will be a surgical intervention to save you first, and in some it's very rare cases that will be a fetal survival, but then we do try our best. I think when I was training there was only one case, and that was not Marfan's with Loeys-Dietz, which with twin pregnancy we dissected, but both babies and the mother was fine, but that was very, very lucky. Moving on, I'll quickly talk about the cardiovascular changes in labour. I think, as I said, the cardiac output increases 20-30% in active phase of labour. Your oxygen consumption increases, and while you contract, the contraction squeezes about 300 to 500 cc of blood of the uterus back into the circulation, so you're heavily volume overloaded. As I say, pregnancy is not easy, but as it sees, but we all go through it. And we also, blood pressure is extremely important during pregnancy, but with each contraction, the blood pressure goes up. Now, anesthesia, I think it's very important that you do have an epidural, and epidural basically takes all the shear stress away because it reduces pain and blood pressure, and hence there's less stress on the aorta as well as the aortic valve, and basically it smoothens the whole process. I think the key with Marfan's is that we have to make sure that you don't have dual ectasia. So most of the people should have a MRI of the spine prior to falling pregnant, because you do not want to puncture the dura. So next slide is, again, postpartum changes. You deliver the baby, everything's perfectly fine, but you have to be mindful of the fact that the volume has decreased, fluid has shifted, and things are heading in a better direction. But at the same time, we have to remember that the shift of extracellular fluid in the vascular components and the peripheral vascular resistance increases. Now, postpartum care. Again, when I mentioned there's a 33% risk that you may dissect after delivering. So practice is that you usually keep your patients in for a week and you get an echocardiogram before you're discharged home. But if you do have a dilated aortic root, you're better served on an ITU care plan, and then discharge home with an echo, and then should be followed up 6 weeks after, and then probably in 6 to 12 months, 6 months down the line, we can consider replacing that root for you. Of course, if you do dissect and if there's a problem, we have to address that straight away. Again, the literature shows us that the risk of dissection remains high in the first 6 to 12 months, and we should keep on reviewing you with echo and MRI scan till we feel that you're comfortable to go ahead and have a aortic root done. Breastfeeding, there are a number of, normally people say that you should not breastfeed if you do have a dilated aorta, because of oxytocin, and it causes lots of changes during pregnancy, but there is nothing conclusive. So I think I find it really challenging to comment on that. The sort of key message again here is contraception. So I would not like to see any of the Marfan patients coming back pregnant again, and especially if they had a dilated aortic root, I probably will drop off my chair, to be honest. And it's very important that you have effective contraception. We normally say depots or a coil would be very valuable here. And the next pregnancy can be planned. Again, the key message here is that you can have children, but the question is that you should have children safely. So moving on to my next slide, we spoke about the Pearce procedure. So this has been around for at least last 10 years, and it's like a covered stent that sort of wraps around the aortic root. Now, I have looked at the literature and my own data. I think we probably set 3 true pregnancy with the Pearce procedures, which has been safe. There has been no problems. One of them was with Loeys-Dietz, who had Pearce procedure done, and I have sat her through 2 pregnancies by now with no problems at all. I think what we will try, if we do have someone between 40 to 45 the aortic root and an intermediate group, it will be quite good to offer that to them to prevent any high-risk type A dissections during pregnancy. Now, the question remains here. Yes, we do wrap the aortic root around, but what's going to happen to the rest of the descending aorta? We cannot prevent a type B dissection. Well, none of us know so far, because it's not been out there for that long, especially with pregnancy. But what I found very interesting was that there's one case report in heart and lung circulation that they managed to save a lady who was pregnant and dissected by not putting on the bypass, baby as well as the mother, because off bypass they managed to wrap that aortic root and get her through pregnancy, which was very, very reassuring to know. But this is the future. I think we will be streamlining our childbearing women, see if they would like to have a Pearce procedure done, so we can safely sit them through pregnancy with some beta blockers and having the aortic root wrapped. This is my high-risk data when we had aortic root dilated and how did we manage. Their numbers are quite small here. There are 23. They are all fall in class 4. And in that 23 patients, if I go down here, I had 4 patients with dilated aortic root, and which we delivered at the Brompton. There has been as such no deaths. They all done very well. None of them required any emergency surgeries, and we managed them very successful through pregnancy, which is quite reassuring to know from our side that we've done well. But at the same time, I don't think so. I would like to be in those shoes when I can't sleep at night knowing someone's aortic root is about 45 and I have to deliver them and get them through pregnancy safely, them as well as their baby. So, and I think, as I emphasize very heavily, preconception counselling is very, very important. Again, it's the data from our centre. We looked at 1,031 patients, and if you go down here, this slide is where we got the connective tissue disorders, and as we know, that's class 3. We have seen these patients here, but I think we would like to see you more coming through that door, because look at this slide. These are my valves and these are my complex congenital. They are already in the system with us and we refer them and people know in the team. But here with this slide, I think we need to do more. It should be higher up, and we should be seeing more patients for preconception counselling to offer what is there for them. Again, I think when we deliver, it's just not me or the obstetrician or the anaesthetist. There are a number of people involved. They are so a bigger team. We are all there to care about you. It's very, very important. And I think where we talk about actually there's an obstetrician, there's a cardiologist, there's an anaesthetist, we need a theatre, we need a vascular surgeon, we need the midwives, we need the neonatal team, we need the Marfan nurse there, we need everyone there. We also have to remember it's equally important that we look after the mental health side of things. It is quite a challenge when you're going through pregnancy, but trust me that if you had the right assessment done, we can sit you through pregnancy safely and you can enjoy it like anyone else. It's just knowing the right facts and being through the right system to be safe and making the whole pregnancy enjoyable. This is what we do. I'm that green one at the back when we have to run a high-risk case, but it is an effort, and we do manage our patients through pregnancy. And I will say that if you do want to go through a pregnancy, please have your pre-assessment done. Come and see us for preconception counselling, and then we will sit you through in a safe centre with safe hands to make sure that things are enjoyable. And on that journey, we will party to you. So ending the talk, I would like any questions from you guys that I can answer for you. I just want to highlight my team includes Professor Gazoulis, Mark Johnson, Miss Roshni Patel, Claudia, and my specialist nurse who plays a major role in setting up things for me is Hajar Habibi. So thank you very much. Any questions? Mariam.
Good morning, and thank you for your session. It was really helpful to know. Yes, I would like to know, how do we get referred to the counselling, genetic counselling? Because me and my son's had the aortic dissection type B, and we're really struggling, and we need the support for the counselling. So how do we get referred? Who do we go to?
It depends upon which centre you are in. For example, I'm based at the Brompton, and I work quite closely with Christoph Ninneber and Fortunate, who's a specialist nurse. So anyone who would like to consider pregnancy gets referred to me by them. And if you really want to see me, to be honest, all you need to ask your GP is just send me a letter and I will plug you in.
Thank you. Thank you.
That's not a problem at all. We're very happy to support anyone. I just need to see a letter and then I can plug you to my service. That's no problem.
Okay, can we have your contact details in the group so that we can?
So my secretary's email is p.cape. I can put that in the chat box, and if the GP can, I'll put that in the chat box later because I think I can't function it at the moment.
Thank you.
And you can get your GP to refer, and I'll be very happy to see you guys.
We invited questions in anticipation of your talk, and one lady, I know that you've integrated it into your presentation. She was worried about the dangers of breastfeeding and the sort of rush of estrogen that she thought could amplify.
I mean, her worry is quite justifiable. And as I said, I looked at all the data. Some people are fine with it. Some people are not fine with them. There is nothing conclusive on that. But I think there was a mouse study done where they thought that, I think I'm quite right to point that out, where they did not just see any change in the aortic root or any problems with that. And there's no case that's been sort of published in literature saying that I was breastfeeding with Marfan's and I dissected my aorta. So we have to take a realistic approach towards that. And then also, when you're breastfeeding, you have to keep in mind that we're putting you back on, if you're taking a beta blocker, you're back on you carry on with your beta blocker. And if you want to introduce an ACE inhibitor, which you can introduce some of them during breastfeeding, I think it should be okay. It varies from case to case. And I think the thing is that you need to ask your team who's looking after you at that time that what their thoughts are, because they will know your aortic diameter, they will know your history in terms of family history of dissection, how much progression there's been, and you have to make a calculated decision. Again, I would say one Marfan can't fit in someone other Marfan's shoes, so it's all very tailor-made medicine when it comes to pregnancy and kids.
Thank you, that's reassuring. And another supporter wrote, she hopes 4 children. She's 32. She's already undergone 3 open heart surgeries. She has confirmed Marfan syndrome and a mechanical valve, and realizes that it's potentially dangerous. I mean, she should seek.
You should come and see us.
And seek, yes, preconception counselling.
It's very important. I think she should come and see us, and then we can talk through that if that's a good idea or is it a bad idea.
Thank you. Are there any further questions for Dr. Rafiq?
Victoria, could I just make a quick comment?
Yeah.
Isma, we did an early survey of the first 20 couples in our practice.
Oh, very amazing.
Who used PGD because we wondered whether to recommend it or not. I think there were 2 interesting points. One was that they switched. So they could start out with PGD, and if they weren't satisfied with the outcome, then they would try naturally with amniocentesis, or vice versa. They could start with amnio and then switch to PGD if they didn't like the outcome. The other thing was that it was brought home to us that a lot of mothers are waiting years to have their children, and we have to warn them all that if you're over 38, you would not be accepted on the NHS for PGD. What do you tell the older mother?
I have to say that I have mentioned that to them before, but at the same time, some of them will quite happily get that funded privately, but I leave that with the GST Trust to see if they will be able to offer that or not. And I think I want to add to your comment as well, where we can't offer PGD to women of 38. Also, I think it's very important to know that which postcode you come from, it depends upon how many cycles you come. For example, if you're going to guys at St. Thomas's, they will only give you 1 cycle of PGD. And then the question comes that if you had 8 embryos and 4 had Marfan's and you got 4 which didn't, let's have an equal split here. You have implanted the first one, you got the baby, what you're going to do with the 3, then I think you, as far as I understand, is that those 3s can be frozen privately. Or you have to pay a small fee. That's what I've heard from a number of patients. But I think you raised a very, very important point. And I think when I look at pregnancy and we're looking at PGD and surrogacy, just not with the Marfan's, but other high-risk cases such as pulmonary hypertension, there are no pathways in place. And I think there should be an exception to such cases. Maybe you and me can work on this and have something on paper and try to support our patients so they can get through this very quickly. And apart from the age, I have to also mention that the waiting list for these patients to get through PGD is also very, very long, which becomes a challenge and they become frustrated with it.
Thank you.
Does anyone have any further questions for Dr. Rafiq? Nothing's emerged in the chat feed that I can see.
You can drop me a line anytime. I'm very happy to answer that. And before I go off, Victoria, you asked me a question and about menopause HRT
Yes.
And I want to highlight to everyone that with Marfan and being on HRT is not an issue at all. I have discussed that very extensively with Roshni Patel and Claudine Domney. I did ask them to come and join me and have one slide up to answer that question. There is nothing published in literature to see any effect on the aorta because of HRT. These two ladies who work in Chelsea and Westminster with me, and one is the lead for HRT, said there should not be any issues in the setting of Marfan's.
That's fantastic to know, because
I think you're copied into that email as well, but I thought I will highlight that one.
potentially, thank you very much. Yeah, because it's increasingly asked of the helpline, and there's nothing definitive, so we can now state that. Thank you.
No worries at all.
Thank you so much.
And now I think thank you for the invite again, and I should disappear. Bye, everyone.
Thank you very much. Thank you. Bye-bye.
Bye.